As far as treatment goes for schizophrenia, one of the things to focus on with the patient is medication compliance, especially considering the negative symptoms of schizophrenia that may never fully improve. It's important to make sure that the patient has a support system outside of the hospital to help them with taking their medications, in addition to close outpatient follow-up. In the hospital, the main goals of treatment are mainly focused on addressing the positive symptoms, such as hallucinations and delusions. Antipsychotics are effective for the positive symptoms of schizophrenia, but not necessarily for the negative symptoms that may also be present. Atypical antipsychotics are oftentimes preferred over first-generation antipsychotics due to a lower risk of extrapyramidal symptoms. If a patient does not improve after an adequate trial of an atypical antipsychotic, it's recommended to switch the patient to a different atypical antipsychotic versus adding another antipsychotic to the patient's medication regimen. This is because antipsychotic polypharmacy can increase the risks of medication interactions and adverse effects, such as extrapyramidal symptoms and metabolic derangements. Evidence has shown that in general, dopamine blockade of 60 to 80% is optimal in the treatment of schizophrenia. Patients typically begin to experience unwanted side effects of too much dopamine blockade, such as Parkinsonism, after more than 80% of dopamine receptors have been blocked. An example of an exception to the 60 to 80% D2 inhibition includes clozapine. Clozapine, an effective antipsychotic, generally shows about 40 to 50% blockade at D2 receptors. However, clozapine also shows some effects at the 5-HT2A and D4 receptors. Another thing to mention regarding longer-term treatment of schizophrenia is that evidence has shown that relapse risk does not decrease as a function of time. For this reason, it's advised to never stop an effective antipsychotic on a patient with chronic schizophrenia. In fact, long-term antipsychotic use in patients with schizophrenia has been associated with increased survival rates.
It's also important to understand how to assess improvement in a patient. In order to do so, you need some understanding of how symptomatology changes with antipsychotic treatment in patients with schizophrenia. In the first week of treatment, you may notice some subtle changes, such as decreased agitation or aggression of a patient and improvements in sleep and appetite. After about 2 to 4 weeks of treatment, patients may exhibit decreased paranoia, perceptual disturbances, and bizarre or disorganized behavior. Thought process may also begin to improve. After about 2 to 3 months of treatment, delusions may decrease in intensity or disturbance. However, delusions may never completely resolve, and the patient may have chronic errors in their reality testing. The important thing here is to consider what the delusions are specifically about and identify if there are any safety concerns associated with the delusion. The hope with antipsychotic treatment in patients with schizophrenia is for the cognitive symptoms and thought process to continue to improve as the months go on. You may also be wondering if there is a more objective measurement of improvement in patients with schizophrenia. There are several different rating scales that have been published. One of the most common scales is the PANSS, which stands for Positive and Negative Symptom Scale. When thinking about how long a patient should remain on an antipsychotic for schizophrenia, it's important to know how many previous exacerbations of psychosis the patient has had in the past. There is evidence that with each psychotic episode, the brain takes some damage, so the goal is to minimize the risk of relapse in these patients.
It's also important to be aware of possible adverse effects of antipsychotics. Neuroleptic malignant syndrome is a life-threatening condition associated with dopamine blockade in the nigrostriatal pathway and hypothalamus. According to the DSM-5, database studies have shown that the incidence of NMS among patients taking antipsychotics is rare at around 0.01 to 0.02%. However, prompt diagnosis and treatment is imperative. Symptoms include high fever, muscle rigidity, tremor, blood pressure changes, mental status changes, and autonomic instability, which can include tachycardia, diaphoresis, and even cardiac arrhythmias. Some adverse effects can be attributed to the receptor actions of specific antipsychotics. For example, antipsychotics exhibit antagonistic action at alpha receptors, which can contribute to orthostatic hypotension. Another adverse effect you may encounter in patients on antipsychotics is hyperprolactinemia. This is due to blockade of dopamine in the tuberoinfundibular pathway of the brain. Extrapyramidal symptoms include Parkinsonism, akathisia, and dystonia, and these are detailed in the DSM-5 in the medication-induced movement disorders section. These effects are due to excessive dopamine blockade in the nigrostriatal pathway. Of note, the reason that some antipsychotics are associated with a lower risk of EPS is thought to be due to the medication effects on other receptors. For example, the 5-HT2A antagonistic action of some atypical antipsychotics increases dopamine in the nigrostriatal pathway in order to prevent dopamine blockade from reaching 100%, which in turn reduces the risk of EPS. Tardive dyskinesia is also a form of EPS that can develop months to years after initiation of an antipsychotic. Some common findings include involuntary movements of the limbs, mouth, and tongue, such as lip smacking. Excessive blockade of the mesolimbic and mesocortical pathways of the brain may lead to worsening negative and cognitive symptoms. This is also known as neuroleptic-induced deficit syndrome. There's also a slight risk of SIADH, which is seen less in patients taking second-generation antipsychotics compared to first-generation antipsychotics. Antipsychotics can also cause multiple metabolic derangements, such as obesity, diabetes, and dyslipidemia.
There are guidelines in place per the American Psychiatric Association, American Association of Clinical Endocrinologists, and the American Diabetes Association for monitoring patients on antipsychotics for metabolic derangements. The following information is gathered from these guidelines. Prior to initiation of antipsychotic treatment, a patient should have some baseline measurements, including weight and BMI, a fasting lipid panel, plasma glucose and A1C, and blood pressure. 4 weeks and 8 weeks after antipsychotic treatment, a patient's weight and BMI should be checked at follow-up. After 12 weeks, weight and BMI should be checked every 3 months and then annually thereafter. 12 weeks after initiation of treatment and then annually thereafter, all baseline measurements should be repeated. If you notice more than 5% weight gain, or if the patient has multiple risk factors for metabolic syndrome, you may also want to consider more frequent metabolic monitoring.
Antipsychotics also carry a black box warning with them. This black box warning states that there is an increased risk of death, mainly cardiovascular or infectious in nature, in patients with dementia-related psychosis. Research has shown that up to 40% of patients with dementia are on an antipsychotic, and follow-up on some placebo-controlled trials revealed that the death rate was 4.5% in patients taking an antipsychotic versus 2.6% in patients on a placebo. A more recent and larger retrospective case control study published in JAMA Psychiatry focused on the number needed to harm. In this study, the number needed to harm was defined as the number of patients with dementia that need to be treated with an antipsychotic in order for one patient to die in 180 days. The study revealed that the number needed to harm for each antipsychotic was statistically significant. The researchers concluded that the effects of antipsychotics on mortality in patients with dementia may be higher than previous studies have shown, and that these effects increase with higher doses. The following medication tables were created as a quick reference guide to antipsychotics that are available in the United States. You can pause the video if you would like to review the information in these tables in more detail. There are also several long-acting injectable antipsychotics that can be used in patients with schizophrenia. The most recent long-acting injectable, with the brand name of Rakindo, was approved by the FDA for use in the United States in January 2023.